Good morning. Finance Committee will come to order. Any citizens signed in to speak to the board, the committee today? We don't see any, so we'll move on to item 3, which is consideration of the minutes from the prior meetings. I'll entertain a motion for approval. A motion by Dr. Weber, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. We'll move on to item 4, CFO report. Ms. Clark. Good morning.
The external auditors start their work today for our annual audit. They will be here for a period of about 4 weeks. And it is a big organization. We have a little bit over $1 billion in assets this year, which you'll see in our final year-end report. But it does take them about 4 weeks to get through all 3 of our companies. And they are scheduled to report back to you their preliminary audit findings. Whoops, rookie mistake. They are scheduled to present their preliminary findings to y'all on your full board meeting on December 14th. So a pretty quick turnaround for them.
Thank you.
But that's all.
All right.
So we are to our September year-end report, and the financials today are what I consider to be our final year-end for fiscal year 17. We are still potentially could receive some final year-end information from the state. Up until the point that the audit is final, these numbers may change, but from my perspective, with the information that we have today, they are final.
Might be some minor adjustments, but basically.
Well, they would have to be pretty major for us to make an adjustment
right.
at this point in time.
Got it.
But these are what I would consider final. And I will go over, when I get to the income statement, some of our year-end entries. We have received our final UC number, what I think is our final UC number, as well as our DISH earnings report and DISRIP. So I'm going to cover our monthly volume statistics. And if you've had a chance to look at this report, I've also inserted some year-end statistics, which are different for year-end. Our admissions for the month of September are up by about 12%. So we had a very busy month compared to our budget. However, admissions were just about equivalent to where they were in August. And our patient days were up slightly from budget as well, about 8%, which meant that our length of stay was slightly down, which is good for our budget, but our CMI was down as well, so those things complemented each other. From an outpatient statistic, from an outpatient statistic standpoint, ED visits, we saw almost 10,800 in our ED this month, down slightly from last month, but up about 4% from expected. And in our urgent care visits, we actually had a slight increase from budget, just over 5,000 visits in urgent care. Clinic visits were up about 3.7% from budget, just over 60,000 clinic visits. And our outpatient visits were up almost 6% from budget. Observation days were right on target. And the surgery graphs at the bottom, inpatient and outpatient surgeries were slightly under budget by 8% and 13% respectively. Invasive labs at the top right continue to be very strong. We saw 622 cases in September alone. So that service line continues to grow. Our psych service line, our patient days were strong this month, up about 2% from budget. Our clinic visits were up 5%. ED is pretty much right on budget, and partial hospitalization is about 10% below budget. So this is where I'm just trying to show you kind of a trend for the last 3 years. You know, there are a lot of areas at JPS that are close to capacity, so there's not a whole lot of trending that's actually happening. But our admissions have grown slightly. If you recall, during the year, we were able to transition one of our floors from a skilled nursing unit over to a inpatient floor. So that has given us a little bit of capacity there. And we've had a 6% growth since last year. Our patient days have grown about 7%, and our CMI has gone down a little bit, as well as our length of stay, which those two you would expect to trend together. Our key outpatient stats, ED, although you would not have thought you could have gotten any more throughput through the ED, that has increased by 6.7% year over year. And just to put that in a daily number, in 15 we saw 328 a day. In 16 it was 330. And this year, it was 352 patients a day through the ED. That's a lot of people going through that area. And in urgent care, which is a separate area, but is often seen as an offload from ED, those numbers have also gone up by 7% this year. And if you looked at that on a daily basis, we had 168 patients that were seen in 17. So, you know, that is just over 500 patients seen daily, just right here on the campus on an urgent basis. Our clinic visits on the top right in 17, that has grown by almost 2%. And, you know, 725,000 patients seen annually. And just to remind you, those clinics are comprised of 17 primary care clinics. That accounts for over half of that volume. We also have 20 school-based clinics, 3 women's services clinics, and then there is another 20 specialty clinics that comprise those numbers. So, and those are all throughout Tarrant County. Some are here on our main campus, but we have a lot of activity throughout the county. And then that total of those, as well as a lot of other of our services, comprise the total outpatient visits of over 1.2 million. And that total has grown over 3.7% for the year. Our other key statistics that we look at each month on an annual basis, observation days has gone down slightly, 4.6%. These are patients that are actually in our beds that do not qualify necessarily for an inpatient stay based on inpatient criteria. So that makes sense because as you have more qualified inpatient stays, you don't have room for observation. We also do better in the ED with holding and hydration. So, you can't have your observation days growing as your capacity for inpatient is growing as well. Invasive lab cases is a new service that we just opened up in 16, and you can see the growth in that service. It started out very strong in 16. We've seen a 7% growth. Our inpatient surgeries and outpatient surgeries, although that we have been talking about this year, we've been under budget, we have seen them stay steady, and even in the outpatient surgery case grow at 1%. The growth that you see in 16 is due to adding some OR capacity. And in the key psych, you can see a steady growth there, especially in 16 when we were able to add additional beds with our Trinity, the Trinity Springs North facility. Clinic visits have grown 27% this year with additional providers and some scheduling. The ED visits have actually gone down by 5% in 17. And our partial hospitalization really got some traction in 16 and has grown by 6% in 17. So that's kind of where our volumes have gone for the year. Our FTEs, this is a really complicated graph, and you'll see it done a different way in October. But we ended up the year at 5.9 FTEs per APD. Now, again, I feel like that's a really important number because when you look at us as an organization, we set our budget probably 14 months ago, and our budgeted volumes are never where the actual volumes come in. So you have to wonder, how are we doing on staffing? And this is a very good indicator of how did you staff to your actual volume. We budgeted to staff 5.96 people per adjusted patient day. We actually were able to perform at 5.9 in a favorable manner to where we thought we would have to staff. So our target was at 5.96. We actually challenged ourselves for a stretch goal of 5.92. We were able to even beat our stretch goal. So kudos to our managers and directors. They're the ones that helped us beat even our stretch goal for that number. If you recall, salaries and benefits is more than half of our operating budget. So this is a big goal for our frontline leaders. On our rev cycle, we watch this pretty closely as well. We're going to end the year with 249 days cash on hand. It's a very strong position. We are glad to have that. And our net accounts receivable days are strong at 53.
Sharon, do we know what an industry standard for cash on hand would be for days for public hospitals?
You know, I don't have that information here with me today, but what we are going to do, hopefully in December, at the December meeting, is bring back a study for you to look at the Commissioner's Court budget presentation. I was asked if we would consider putting a little bit more into the JPS Future Fund. And part of my process in doing so is gathering some information on other public facilities and where their days cash on hand is, as well as S&P and Moody's ratings. And we'll be
Yeah.
discussing it
That was my
then.
next question, is the ratings, what
Yeah.
they would ask. Okay.
Yeah. So I want to kind of compile all of that information for you to look at.
Actually, the days cash on hand is pretty good.
Yes.
New York City hospital system is 18 days as of 2017. But that's unusual.
Yeah, we don't want to be 18 days.
No. No.
You want to think about it?
No, that's.
I want to be better than any other public hospital in Texas for sure, but I just want, there's an appropriate amount, right? So you don't want money not doing anything, sitting around not doing
Correct.
anything.
And, you know, just more from a cash management standpoint, we do, as a public facility, we are very conscientious of trying to maximize the return that we are able to get on our excess cash. We're subject to the Public Funds Investment Act, so we're very limited in what we can invest our monies in, very conservative nature. But we have been able to reinvest our money to get what we can from it. So that's something that we have folks looking at daily and making sure that we do invest our monies. And we've, you know, gotten good investments, and you can see that from our other operating income.
Right, well, and there's investments and there's other use of the funds, you know, like you said, the future
Right.
fund and other kinds of services, so.
Sure. You bet.
Sir.
It's just a correlation. I've been looking at length of stay for several months, and we've really been doing good. Length of stay numbers continue to be lower than budget and lower than the previous year. But our case mix index doesn't represent the same, similar reduction. So is that a function of efficiency, that length of stay reduction?
So I'm gonna kind of jump out on a limb a bit. Our volumes have also been extremely high. So as we reach capacity, you're also challenged with, you know, high numbers in the ED and trying to find beds for those folks that are coming in. And a lot of times that challenge alone will drive down length of stay. But I do know for the last 12 to 18 months, we have had initiatives that have, you know, as an inpatient facility, a huge initiative in cost containment is to manage that length of stay. But that is heightened when you have an ED as full as we have, because part of that offload and throughput for your ED is to get those inpatients into a bed. Because until you can't turn that room over, it's just locked down.
Well,
So.
that's been a 3 or 4 year effort, is to try to facilitate getting people out.
Mhm.
And it looks, I mean, all the indicators look like that we're doing a whole lot better.
Yes.
So.
So,
That's good. That's good.
Which- I don't have 2016 number, but 2015 number for Parkland was 68. Went from 121 prior year, so I'm not sure what they're doing on 2016 on days on hand. 68 what? Days, cash on hand, for the other side.
Wow. We
yeah,
want
I
to be
mean,
better than that
I
too.
would say 150 is a comfort level, if you were guessing. I can't speak to what a
We'll do 149
rating
just to keep you on edge.
agency
Yeah.
would speak to.
We're okay, yeah.
Cities always get visits from our bond raters if you go below 90.
Well, 90. We want Sharon to sleep at night, so we'll.
Please, yes, whoops. We always look at our payer mix slide. It has not changed significantly. So unless anybody has any questions on that. Our connection enrollment truly has leveled out around 40,000 members for the year. So
It's not
no
leveled. We added 500 so it's
We
not
did,
level.
we added 500 this month,
Right,
and
celebrate wins when you get them.
the enrollment team will continue to work. So I don't have my John Madden board here for those of us who were in the John Madden era. All of us at the table are good. I'm not gonna see the laughter that goes on behind me. But, so I've got it's a very confusing month to talk about, so I'm gonna do this in several pieces, so I hope you can kind of follow along. First of all, I want to tell you how excited I am to report to you that we have closed the year, and I can report to you a positive operating margin of $3 million for the fiscal year of 17. That is an achievement that I was not certain up until probably the first couple of weeks of October that I would be able to sit here and tell you that we were in a positive operating margin status. And there were a couple of things that allowed that to happen, both of them which are state-driven funding items. So the way that I'm going to try to cover this month's close is to go over with you what some of our year-end entries were. And then I'm going to try to cover the month of September and tell you where those year-end entries fell in the month while I'm covering the September results. And then I'm going to go back and tell you about the year-end and year-to-date. So if you'll kind of stick with me through those three processes. We did have year-end entries of close to $10 million that were a pickup for JPS. And that is what helped the $6.8 million positive result for the month of September. The biggest of those were, we had a DSRIP achievement level. And again, you know, when I talked about the FTE number, the FTE per APD and what we achieved on a monthly basis in the year-to-date being a frontline achievement, the DSRIP achievement, we received from our metrics 94% in DSRIP. We had targeted just under 90%. There are hundreds of people and probably thousands of people that it takes the effort all year long to make sure that we hit those district metrics throughout our district. And to be able to achieve 94% of those metrics was a wonderful achievement. And, you know, we're talking about, I think, close to 40 metrics. And again, these are throughout the district, but we were able to recognize an additional $7.2 million in district funding from the 89% level to the 94% level. So in total, we will be able to achieve $54 million in district this year. But that was an additional pickup of $7 million. I'm also going to talk about UC again and help walk you through what happened with UC. I recorded a hit of $3.1 million in UC for this month. So if you recall, right after we closed, we had a change from 15 to 16 of $9.5 million for UC, our uncompensated care fund, which we don't have as much or any control over like we do our district dollars and the achievement that we have there. We had budgeted, and this is a budget gap. So what we lost 15 to 16, we assumed we were not going to receive our in year 16. So that was a budget gap, and we have been accruing $833,000 less each month because I didn't want it to be a $10 million surprise today.
We don't find this out until September, right?
We don't find out the
That's
calculations.
the last month of
Well,
our
we
budget.
actually found out in August.
Oh, okay.
So,
Well-
but we had expected that the pool would recalculate similarly to 16. We found out in September of last year, late August, 1st of September. So, not to be surprised, we knew that 10 million was coming. In August, we found out about the ambulatory change. That was another $9.5 million change. Now,
To the negative.
to the negative.
Yes.
An additional. We had not accrued for that, and we actually changed our 18 budget for that number. And that was not a lot of fun. So, and we also, along with many, many other hospitals within Texas, appealed to HHSC. HHSC did send out an email at the very end of September, right before we closed, to say we are going to recalculate. And we found out that we picked up an additional 6.4. So the net that we lost this year, and you see because of the ambulatory pool, was only 3.1 million. So I did not have to take an additional 9.5 million hit. It was only 3.1. So the net hit that I had to take was 3.1 in September. So as I told my leadership group, it's all in the presentation. So I felt kind of lucky that I wasn't having to record 9.5 additional. It was just 3.1.
Sharon, can I just say one thing, and appreciate all the work you did. For true transparency, we found out, you were notified, correct me, we found out on the Wednesday before this board voted on the budget on Thursday. And due to knowing that, we adjusted the budget based on those numbers. So the board truly looked at the worst-case scenario. There was discussion, if many of you may recall, that we thought there may be somewhat of a change. We didn't know there were certain things that was going to be done by the leadership team of the hospital. And so I appreciate all the work that happened, but I just want everybody to remember, we walked into our budget finding that out on the day before, and we didn't bypass it, say, let's don't worry about it, and we might get a better deal. I'm great that we got a better deal, but it took some work by staff and by other people that associated. So I just want to say thank you. But the board voted for the budget looking at the worst-case scenario. So again, due to our continuing, making sure the board, I mean, we deal with what hits us, that literally hit us on the Wednesday afternoon before the board voted on Thursday, and the commissioners saw it on Tuesday. So anyway, thank you.
And I don't want us to skip over this point. This is a big deal. I mean, the difference between our staff's performance is $1.4 million per percentage point increase in our metrics on DSRIP. So we went from 89% to 94%, saw a $7 million pickup. That's huge. And, you know, DSRIP has always been one of those things we've looked at and said, God, I hope we do good on this, because we put so much weight behind it, and everybody else in the world puts so much weight behind it. We need to, this is an attaboy. This is a
Yeah,
big deal.
it is a big
Be able to
deal,
go
Trent.
from that level of performance to 94%. I don't know where I don't know what the sky the limit here is and how far we can get, but I would guess that we're probably among the highest receivers in the country when it comes to the percentage of DSRIP metrics.
I
And I
agree.
certainly like to keep that and know what that is relative to other entities, but great job. I mean,
Yeah,
that's a big
agreed.
deal. Fantastic.
Great, Trent.
Right.
If you recall, going into even the compensation discussions about, these are huge numbers, and we deal with them as they come in, but, you know, no one wants to pat yourself on the back because we never know what's going to happen tomorrow with some of our funding mechanisms. But again, my entire point, and your point well made, that we commend the staff, and in what they did.
Yeah.
As everybody knows, we sat here for the last 12 months, and every month, Sharon said, that $833,000 that we're taking as a technical loss each month in our budget in the prior 12 months was due to a $10 million that you found out after budget last year, which brings another question. You said periodically there may ought to be a time during the year when these big swings, you brought that up and previously, and we so noted that, and when we have an off-site or we discuss some of these things, that might be something we want to look at, Chuck. So again, thank you very much for what you and staff did.
So those are some of the largest entries. We also, I've talked about this previously, we were able to also record $2.7 million of additional tobacco fund revenue for this year. We were not expecting that large of an amount. The state, from a big picture, allocated more discretionary funds into the tobacco settlement revenue this year. So that was a nice settlement. And also a pickup included in that $10 million because of some of the ambulatory redistribution. Our IGT expense was lower than we had budgeted. So that was a pickup at year end, interestingly enough. So that was some of the larger year end adjustments that we had. And so if you kind of took away those year end adjustments, the performance, the monthly performance in September was not that much different from the performance that we had for the prior months of August and July and June that the medical center saw. We had about a $3.3 million loss from operations. And if you start looking at the line-by-line variances there, the net patient service revenue, we actually came in about $650,000 ahead of budget. Most of that was due to the volumes that we talked about in the monthly graph. Mainly inpatient volumes were up by about 2%, and the outpatient revenue was up by about 1%. And we've talked about the dish and the waiver variance there of the $5 million. $7.2 million pickup in DSRIP, and that was offset by about a $3 million hit in the UC as we adjusted that for the final number. The other operating revenue of $3.3 million variance, the majority of that is the $2.7 million recognition of the tobacco settlement, and we did have about $240,000 of the PAP drug revenue recognition that's offset by some supply expense in the bottom coming
That's
up.
all under other operating?
That is all other operating. The tobacco settlement is recorded in that line item.
Okay.
And then when you drop down to other operating expense in the salary, if you locate that line item, you can see that that was over. About half of that overage is due to the volumes that we were seeing. If you remember, we were about 12% over in patient days and admissions. And then we also had some incentive accrual as well. And on a monthly basis, our FTE per APD was at 5.84 compared to a 6.02 budget. So favorable on a monthly basis. In benefits, we actually had a savings of $1.1 million, and that was due to our year-end workers' comp assessment by our actuaries. We actually were performing better this year, as well as our pension actuarial assessment. And because of our pension assets earning more, we did not have to fund as much into our pension asset for the last 2 months. So there was a pickup. Purchase service, it looks like it's right on budget, but we had a year-end entry between us and the Acclaim company, which we'll talk about here in a minute, of about $2 million. When we took a deep dive into Acclaim, we were talking about there were some settlements that we needed to make with Acclaim for medical director reimbursements, as well as transferred services and some contracted rates. So it's an expense to the medical center, and we are going to show it as income to Acclaim, part of other revenue. So that's a cost. And then the IGT credit is actually offset in the purchase service line that I was talking about as a year-end entry. And the supply overage is part of our PAP drug that I talked about in other operating revenue. And that kind of summarizes the month of September. That's a lot of numbers to go over. Are there any questions on the month? Because I'm going to kind of do a quick overview of year-to-date, since it's the year. Okay, so for the year, again, I just want to point out, we had a $3 million income from operations. When you add in our interest earnings, our non-operating revenue of $7.8 million, that brings us to a total of $10.8. Our budgeted income from operations was $13.6. So there's a gap of about $10.7 million. I do want to point out the biggest variance there is going to be the UC revenue. We missed our UC budget by $12.7 million. Again, it's the $9.6 million that we have not been accruing for all year, that $833,000. I'm so glad this year is going to be wrapped up. And the $3.1 million hit that I recorded for the current year's recalculation. So that's the 12.7 shortfall from budget for UC. We did have a $7.2 million pickup for the year compared to budget for DSRIP. So those two things kind of offset each other when you look at that one line item for the DISH waiver line. Again, on the top line, our net patient service revenue, we came in at 3.8% ahead. The $13.2 million pickup, half of that is due to volume. We did have our inpatient revenue, net revenue was up by about 3%. Our outpatient was up by 0.8%. So big inpatient volumes, but about half of that 13 million was due to volume and about half was due to price. So we had great rev cycle initiatives in place this year. And if we would not have had that, we would have only picked up about half of that $13 million. So we have good plans in place for next year as well. The other operating line item, again, about $3 million is the tobacco revenue. We have about $2.5 million that is PAP drugs that kind of does not have a bottom line impact because we'll see some expenses down there in the bottom. It's an income item and then it's an expense item. So, and then we have had a lot of activity with grants this year. So included in that $7.6 million is close to $1 million of additional grant revenue that was not budgeted. and most of that is in the Ryan White grant
Did
area.
grants, I thought you said France, so I'm sorry then.
No, we're pretty much local to Tarrant County. So, yeah, it's $1 million in grant revenue. Salaries, again, even though they are over budget, we have done great work in managing the FTEs per APD there. And we've talked about those a lot. So those were really most of my prepared comments, unless anyone else has questions about the medical center.
Any questions for Sharon on these? Okay.
I have a small, I'm not sure if it should be a concern or not, but if you look at prior year revenue, we increased revenue by 33 million, but we increased about $50 million in expense.
What are you looking at, ET?
The 871 million of prior year, and the revenue for the last year is 904. So that's a $33 million increase, but our expense went $50 million more. So. You see, when it's a 63% increase in expense compared to the revenue. It's just a thought that we need to pay attention to it.
Why does it concern you?
Our bottom line growth much faster than the top line, the revenue line. You got a $33 million pickup in revenue, but you got a $50 million pickup in expense.
Okay.
Look pretty.
So our cash flow, we don't usually spend a whole lot of time on the cash flow, but it is positive. From a year-end perspective, we were able to pick up about $33 million worth of cash this year. Just wanted to point that out. So for a claim, I'm not going to spend a whole lot of time on, I'm just going to go to their income statement. For a claim, they had, again, a fairly normal operating month. Oops, wrong slide. They had a fairly normal operating month. There are 2 year-end entries that I do that offset each other for the most part that I need to point out. The first one that I want to talk about is on the third line item in other operating revenue, and that is the $2.2 million payment from the medical center that I just talked about that was in the purchase service expense that came from the medical center to a claim. So that's the intercompany transfer that we were talking about there. The other overage is kind of the normal activity that comes in for the surgical contract and the neurosurgery contract that we talk about every month for them. The other unique item that happened in a claim was, as a year-end entry, I wanted to make sure that we took an opportunity to look at the accounts receivable in that company as a first-year startup. And because we were working on credentialing for certain physicians and with some new managed care companies, there had been some aged accounts, and there are also a couple of managed care issues, very specific issues that we're working through. And I wanted to reserve specifically for those. Not that we think that they are not recoverable, but I want to make sure that we had an adequate reserve for those so that they would not impact fiscal year 18. So we took some additional reserves in that patient service revenue. We had the ability to do that, and what I also had a claim due is we matched the aging principles that we had on the medical center to what we also were going to do in a claim. So we kind of did a balance sheet aging on a claim for those receivables, and we started to reserve everything over a certain age, like 180 days, and took a reserve on those accounts. And we will continue to do that into fiscal year 18. And that is just a one-time entry, and I wanted to do that before we close 17. So those are the 2 year-end entries that impacted. And again, I can go through and kind of explain the variances, but there's no unique variances in September. From a year-to-date standpoint, a claim closed at 14.7 million loss compared to the budgeted loss of 8.2 million. And that is where we had expected them, based on our prior conversations, to close. Most of that $6.5 million gap was due to kind of not having great information as we created the budget back 14 months ago. The acclaimed company that we have today is not necessarily the company that we thought Acclaim was going to be 14 months ago. We didn't understand that we were going to have 360 employed providers. We thought some of them would be contracted and some of them would be employed. So about $3.4 million of that difference came from some incorrect information that we had when we created the budget. There were also close to $4 million of one-time expenses that we did not anticipate as a startup company. And we had talked about that in a closed session with this group. And then offsetting that, we had $1 million of pickup with the EMR revenue that we'd received and booked a couple of months ago. So that's kind of how we got to that $6.5 million difference, just as a reminder from budget. Are there any questions about a claim?
Yeah, just, I mean, big picture, especially knowing what we had to do to last year's budget. When we budgeted this year for a claim, Sharon, have we made all those ongoing adjustments so that we feel like we've got a better handle on what's going to happen in this current fiscal year?
We did. If I recall, the budget for a claim is like right at 12.5 million loss. That's about a $65,000 or $70,000 loss per provider. The one big unknown that we had when we approved the budget for a claim was the surgical contract. And right now we are, James and I are actually working on making sure that the pool of money that we budgeted was adequate, and I feel like we're good. It may not be in exactly the right categories where we budgeted it, but I think that 12.7 is good.
And Charlie, I mean, I don't sit in the acclaim meetings, and so I don't stay up with it, but I mean, do you guys feel better about where we're headed in terms of the forecasts, expenses and revenues, and or you think we're on the right path? Because I know there was a lot of consternation in the first year. Y'all feel like we're headed the right direction?
I think so.
Good.
Yeah, I think along those lines, Sharon's done a great job of keeping a claim up. We just had a joint meeting of the executive committee and a claim board of directors. We had a joint meeting this past Monday night that lasted 5 to 7, whatever. The numbers were looked at even by that group. But yeah, I think there's been a pretty substantial amount of forecasting. As you remember, we had consultants even come in and look at some of that last year numbers. They matched up to Sharon's numbers. I think if there's anything that was missed is in the first year of any new business, There's a lot of unknowns.
Sure.
When you do something that's, I'll use the word complicated, it's putting that all together. And now that the positions are on, over here, the providers are here, I think it gives Sheridan a better chance, a better way of saying what's the numbers and expenses.
I agree.
Chuck, I mean, but I think that first year was an assumption.
Sure.
There's some things are gonna happen, that's all they had. That, and we told Commissioners Court, going back and looking at it a year ago, this is the first year, and there's a lot of assumptions. Do we get those clinics in? Do we get the providers in? Do we get those individuals on board? And I think the number looked large compared to the assumptions. I think this year it's more of a detailed
I
number.
feel good that going forward, we've got the right model for retaining and attracting providers, to keep that provider number up, because that's been one of the biggest challenges.
I think that's an area, we'll have to have some continual looking to see, that whole compensate, that whole area, to sit here and say, yes, don't think there may be some additional as we go forward.
Yeah.
I think there would be, Jim.
Okay.
I
Thank
think going into the, Chuck, you chair that executive committee, I think we agree that we've got about as solid a footing now, based on all the information we know, that we think that number's pretty good.
Yeah, I think Karen Van Wagner would say it's sort of a baby
Yeah.
organization.
Yeah.
But I think it's maturing very, very quickly.
Good.
It's, I think
Thank
it's,
you.
I mean, I agree with majority of what you guys saying. It's mature correctly, but we also changing the model to more reaching out to patient. So we have coverage. I just want to make sure they have access. And I think the next, going forward, what we need to look at to measure to make sure that if they have access to care.
Yeah.
And then you start measuring the utilization, all that stuff to see, because if this is a cost center for us, what's the overall system? Because if they can't get access, we'll make more money. I want to make sure that we are doing it the right way. But there's no indication we're not, but just be on the lookout for it.
Yeah, good point. I think that I'd say this, that there's been a lot of change.
Sure.
Whether it's in the model and where we're going, what the direction the board set. I think we've gotten to their trend. I think there has been a lot of change. Hopefully the one thing that hadn't changed is what we're all here for, is to make sure the patient is
Yeah.
taken care of. So I think there's going to be a constant address on quality, those issues, accountability, those kind of things. I think you'll see that more, because that's the way it was going.
Yeah.
And at the end of the day, we talked about all the some things where assumptions made. The main thing was to take care of the patients, or whether that's access, what DT's talking about, or whether it's quality in the clinics.
Yeah, I mean, I'm only asking it prospectively. I mean, we all knew that first year would be tough. I think to DT's point, the only thing when you look at it is you want to make sure that we're continuing to fill that provider.
Correct.
Because that's what's going to impact whether or not we're going to be able to see these folks.
Correct.
And if we've got the right model in place to attract the providers, and if we've set the right contract parameters in place to attract the providers, then it's just a matter of getting out there and getting it
Yeah,
done.
and I think the other thing is, because it was an assumption year, and the numbers came in, as Sharon just indicated, larger maybe in the loss. When you take that and you put it to the big system,
Yeah.
you know, again, as we can say, the mothership, the system is financially, we know the
Sure,
numbers are on that.
sure.
If you get over there, it's like, oh my gracious, we were more than double what we thought we'd take a loss.
Sure.
Well, when you add that back into the system, it's a pretty minute amount.
Oh, I agree.
That's not a justification, it's just the
Sure.
reality of that first.
No, I agree. Okay, thank you. Steve?
So, yeah, the last slide in here is our consolidated. You know, we've already covered the hospital, a claim. You layer in the foundation. That is the assets. Sorry about that. You layer in the foundation, and just looking at the year-to-date number, bottom line, we are closing the year at a $3.8 million deficit. And again, it was a tough year this year. And but I don't foresee any adjustments going forward unless we get new information from the state.
I'll draw your attention to the total assets line.
Yes, next page. Promise to do that. Yeah, we're right at $1,032,000.
$1 billion.
So, Huh?
A billion.
Yes,
We
sorry,
cleared-
billion. I have trouble with those last three. Yes, a billion. And, you know, from a combined standpoint, these are not consolidated numbers, but, we're growing every year, so.
Any further questions for Sharon?
This could be a far-reaching question, but when you look at the bottom line that everything now is reported in, does this say we could afford a bond program?
That is a loaded question. There's a lot that has to be considered when we start to look at the pro forma for the bond issue. So you can't just layer on the debt service for that, just the interest cost. And what we're gonna have to try to figure out is what expense reduction is coming on and coming off the books. I think one of the biggest questions that I'm gonna have to work with someone on is the overhead costs and what's coming off as far as plant and facility, and what savings are we gonna have from a building standpoint. So as we get closer to design, and
Well,
there's
it's
just a
both-
lot of questions.
It's
that
both
are-
sides of the ledger too, though. I mean, there's additional revenue from the additional plants that we built, the additional capacity that we built.
That's questions too, yes.
Okay.
So, there's all kinds of, it's more complicated than that. It's going to be a very tight, pro forma.
I would
You
say,
know,
can we afford not to?
Yeah, that's
Well, yeah.
where Ralph's going.
It's more than just the financial argument, and that's what we're gonna have to get together and work through.
Yep. Good question, though. Okay, well, I'll entertain a motion to accept Ms. Clark's financial report.
So moved.
Second.
Second by Dr. Casey. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Sharon. Well, nice of you to join us, Mr. Early. Thank you. Sleep late?
Yeah.
All right.
Sharon will tell you about the budget changes later.
There's one category.
Have we discussed the allocation for a shaver in our financial budget?
Oh, huh? Lashing out at me. So we'll move to item 5B. Katie Rutherford.
Good morning.
Good morning. We are well.
Yes.
Okay. All right, so I'm here to gain your approval for a contract.
Yes, ma'am.
We issued an RFP for our new claims, for claims processing. There were 8 bidders, and we selected through the RFP committee in Thrive, which is our incumbent vendor. They offered some enhancements and some new processes for us, and they also cut us a discount. So annually, we'll be saving $7,500. It's not as big as Kathleen can usually do, but we're getting extra enhancements that will better help us with our claim status. So we're really excited to see that.
As my mom says, a buck's a buck, so we'll take
That's
it.
right.
All right. Any questions for Katie on this item?
I do,
Yes.
but just a disclaimer, I used to run this company, so just want to make sure everybody knows.
So that's
Are
why
you-
they gave
No
us the discount.
complicated.
Well, is that why we get it cheaper now?
I have nothing to do.
Oh, I didn't ask about that.
8 years.
Ouch.
I'll be sure and ask that next time.
I have a question for you on the claims management. As we go deeper and deeper into Medicare Advantage and all that stuff, are they transmitting the CPT-2 coding?
CPT coding, I don't know, but
The CPT-2 coding.
I
There's a
don't
lot
know,
of
but
stuff that we do on the A1C and all that stuff, the flu shot and all that stuff, have to be reported into, along with the line of service CPT-4. So I just want to make sure that we're picking that up and send it through also as well.
I can double check that. Thank you. Yeah.
Is there a reason why we choose CDM manager versus CDM master?
Well, CDM manager has one more year left on its contract. We will, and that's why you'll see the difference in price, the 39,000. We will RFP that next year.
Because it's a cheaper version, but it's unmatched, so you lose a lot.
Yeah, Knowledge Source and CDM manager both will run out next year.
In terms of so does the claim include the CCA, the child capture audit?
No.
also as well?
No, we did not go with that.
Do we have the child capture audit?
We didn't include that in the RFP. It's a separate line of business, and we didn't include that.
Again, you lost me in
Child capture.
Thrive offers a product line called CCA Charge Capture Audit, and that was not included in our RFP, and so we would have had to reissue, and in the essence of time, we did not pursue.
Is to capture potential lost revenue on that. Because when you have missing charges and all that stuff,
What,
then you can make a determination
so,
that do I want to stop the claim because I'm missing a $10 or $20 charge? Or do I just let it go because it's a $100,000 claim? Just let it go and do an appeal later on, or you stop if it's a large enough dollar amount.
So,
that you can get
so
things
what,
done.
what DT's talking about is a process where InThrive would, if you had, maybe you had some of the edits we already have in Epic. But some of the other more sophisticated edits might be, and this is real simple and we already have it, but if you have an injection, there's also an administration fee that goes with that. So that's an edit that says you can't have one without the other. InThrive offers a package that says you have this big surgery with all these different line items, and maybe we missed one little something. InThrive would then say, oh, have you thought about this? But again, we didn't consider that in the RFP, and so we can certainly look at that at a later time. Our goal is to work most of our edits in Epic as the source of truth system that we have, and so if we can back up those edits at the get-go, then we don't have to rely on a different system for those.
It's a 50-50 because if you catch that it's the wrong payer, then your edit will pick up the wrong, and then when you flip to the right one, you don't have the source anymore. So it's different approach. Some you can't just do upstream, especially when you deal with MTLR. You don't know who they are yet until you identify insurance later on down the road. So moving too far upstream, you may have to do it multiple times without the yield, but there are things that you can catch up front too. So it's,
Any other questions for Sharon or Katie? Entertain a motion to approve. Motion by Dr. Schrader, second by Dr. Weber. All in favor, please say aye. Aye. Opposed, motion passes. Oh, and one abstention from Mr. Nguyen. Motion passes. Thank you, Katie. And item C.
Right, so our next contract for approval is Network Science Incorporated. They are a company that provides financial assistance software. We issued an RFP at the normal, for the normal end of our current contract. They are a company that sort of promotes financial assistance in big hospital districts. What they do is they allow a family to be screened by member for individual programs, which includes not only our Connection Charity program, but government programs, grants. They're set up for more of a safety net hospital screening as opposed to maybe a for-profit or other type of facility. They are in other Texas large hospital districts, and they are Epic savvy. They have the interfaces that go back and forth, and so it will really streamline the time that it takes for our eligibility specialists to screen a patient, and it'll be more accurate reporting.
is this the software you put in front of the counselor, or?
So
Or is it
this-
the service itself?
It's the software.
Software.
Mhm. They branded it Verity. You may have heard of it.
But how is this different from the two vendors you chose the other day?
Right, so this is the software. Currently, we are using Experian, and the eligibility specialist will interview the family and put it all in the computer, and it says, you are eligible for this program. Most of it's connection. The vendors that we brought on in April are service, that they individually go talk to a family, usually inpatient, and they will screen them for a government program.
What is that, what they do, bounce and check for eligibility for Medicaid and all that stuff also as well? So
Yes.
Are we double, triple, double?
Not
paying?
really.
What-
The families that come to the eligibility centers haven't been screened for Medicaid typically. And so we'll do the preliminary. If in fact the patient is then screened eligible for Medicaid, the system, Verity, will complete an application for Medicaid. We have HHS, or Health and Human Services folks on campus, and we can give them the application.
And they charge the transaction fee or percentage of revenue,
Which one?
this one?
It's a maintenance fee,
Maintenance fee?
Mhm. Subscription fee.
Should you be concerning too many people access the patient and they may be flip-flopping some of the patient information, the address and all that stuff that can confuse you guys on the back end for billing?
I don't think so. So what's different about Verity or Network Science is we will have an HL7 from Epic to Verity. So that information will actually be more in line with what we do today, where the eligibility specialist has to type in all of the information separately from Epic. And so those two will then match.
So they do skip tracing and all that stuff to verify information?
Well, we use Experian for address checking
And
through registration.
And the transaction that they do, is that passed through?
Experian? No, we pay for that.
We pay for it? What I'm concerned is too many vendor checking for verification, and then we just pay the toll booth every time they access.
Yeah, no, we only have one vendor for address checking.
What was your concern with that?
Too many source of information to check, to find insurance for people, and too many toll booths for each one of them.
Duplication expense.
Any other questions for Kate?
Move to approve.
Motion by Mr. Petty.
Second.
Second by Dr. Casey. Any further questions?
All
All in favor?
in favor, please say aye. Opposed? Motion passes. Thank you, Katie.
Thanks. Thank y'all.
D,
Mr. Whitman.
Good morning.
Morning.
This is a request for a maintenance agreement with Talus for our medication management system at the jail. And this is not a request for approval based on the dollar amount, it's a request for approval based on a sole source agreement. There's 3 manufacturers for medication management systems, Parata, Pyxis, and Talus. We bid this about 3 years ago. Talus was selected, and we're requesting approval to pursue a maintenance agreement with this company. This is not a fashion statement.
Yeah. You are, in this particular motion, you would be approving the exception to bid because of the impracticality from the standpoint that there are some copyright issues here related to the equipment it's serving, that we would lose the warranties as well if we were to go with someone else on this. So that's the reason there's an exception here. So you're approving not only exception to bid, but you're also approving the contract itself. Okay?
Any questions for council or Bill?
Move for approval or second. Trent, I think Trent motioned, so I'll second.
Motion by Dr. Casey, a second by Mr. Powell. But I want to make sure, any questions for Bill or for council before we? All right, all in favor, please say aye. Opposed? Motion passes. Thank you, Bill. Hello, Ms. Burnside.
Hello.
Item E.
Good morning, everyone.
Good morning.
I'm here to ask your approval for the First Amendment to the Professional Services Agreement between Pacific Interpreters and Tarrant County Hospital District. Pacific Interpreters is the company that provides our language line service for our interpreters and helps with our patient interactions. This amount is approved in the budget and is an unchanged rate from the discounted rate that we received last year from this company.
Okay. For Laura's description, any questions? Entertain a motion.
So moved.
Motion by Dr. Weber, Dr. Casey, a second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Laura. Mr. Mendenhall, item F.
Nice tie.
Oh, my goodness. I should say the same to you, Dr. Weber. Thank you very much. This morning, I'm bringing to you a recommendation for maintenance that on our VMware software. Our VMware software is what manages all of our virtual environment. We have over 800 virtual servers that we run, and this software helps consolidate all those physical servers into virtual servers. And this is a 3-year maintenance agreement to continue keeping those alive.
Anybody understand a single word he just said? No? Okay.
Second. Mike. Exactly. That's right.
Any questions for David?
Is there a need for a motion?
No, I'm sure it's very important, David. Any questions for David before we move on?
So moved.
We have a motion by Mr. Petty, a second by Dr. Casey. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, David. Ms. Walker, item G. Good morning, Pia.
Good morning, everyone.
Good morning. Still morning.
This morning, I would like to ask for your approval of a self-insured healthcare plan stop-loss insurance provided by American Insurance Company. Of course, for this, there is no change in deductible. This is our stop-loss provider that we utilize to ensure that we cover our high claims within our organization. As you can see, there is a slight increase in the premium of about 5%, and that is due to the number of higher stop loss that we receive for this fiscal year.
We had some in 2017.
Yes, sir.
So premium, but our never mind, I forgot what question I was going to ask you. It can't be really very important, could it have been? Okay, you've heard the description. Any questions for Pia?
Yes.
How many years have we had this provider?
Well, this will be a new provider.
Okay.
We, in the past, have had Reliance.
Okay.
Because we received 6 for this fiscal year. It was going to be a higher cost. We work closely with our broker, and they went to market, and this is the best cost that we get for the organization.
This is the, for healthcare stop loss, right?
Mm-hmm.
And at what amount is the stop loss kicks in?
After the 500,000.
5,000.
Yeah.
Is it for the accumulated or just individual it kicks in?
I'm sorry, can you?
Individual or accumulated?
I think it's individual claims, right?
The individual claim that we receive, yes. Mhm.
Yeah. Get it accumulative, that would be really nice. We could get that.
Yeah.
Yeah.
And we pay for number of head count, or is it?
For this
on the
past
amount
year,
that
we
hit a certain
received
threshold?
6.
I'm sorry.
We received 6 this past year for that amount.
We received,
6.
Yeah, we had
over that
6
amount.
claims over
6
500.
claims, yes.
but the premium is based on every employee and members that we have, or is it when the dollar crosses a certain threshold, that's we start paying for it? In terms
Can
of
you repeat that
premium
question?
calculation.
I'm sorry, can you say that one more time?
On the premium, Is it per head count? I was asking, is it per head count or per claim that exceeds certain dollar amount?
It's
when
the
you start?
per claim that receives that amount. Yes, it's the claim amount. So anytime when we go over a certain claim amount and the claim amount exceeds what the market is seeing and what they're trending, we're going to see a higher cost in our stop loss amounts.
But the base price is based on 6,500 employees.
Yes.
I mean, the fundamental price is based on 6,500 employees, but then it's subject to claim experience.
Right, because there's some premium that you don't pay until you start seeing claims that approaching 100,000, even though it's at 500,000 or whatever.
Oh, no, we get to pay all the time.
Yeah, you pay higher amount.
Right.
That's fine.
Any further questions for Pia?
No.
We have a motion by Mr. Bose.
Second.
Second by Dr. Schrader. All in favor, please say aye. Opposed? Motion passes. Thank you,
Thank you,
Pia.
thank you.
Council, any reports?
Yeah, our monthly report on contracts under $200,000 for the month of September 2017, there were 41 contracts under $200,000 that did not come to you, that were within the authority of Robert and his staff that were negotiated.
Okay, but those are on the portal for us.
They are
for our
posted on the
review.
portal, yes.
All right.
Monthly.
We have nothing in closed. If there are no further issues, yes, sir.
Chair, I'd just like to mention, if she would like to, Jenny's sitting back there from Commissioner Wynn's office, and she has two of her interns that are interning with the Commissioner's office. So thank y'all for being here. And
Thank
Jenny,
you
if
for
you want
being
to
here.
introduce them, you certainly can, but thank y'all for being here today. Thank you.
All right, thank you for that. All right, no further business. We're adjourned.
All right.